Hi, my name's Suzanne Johnson and I'm a gynaecologist from Southampton. This is a talk about diagnosing endometriosis on transvaginal ultrasound, the transition to expert. In this talk, I'm going to talk about what endometriosis looks like on ultrasound and how you can learn how to do this. And a quick warning that this presentation contains surgical images. People always said you cannot see endometriosis on ultrasound. This is really not true, and I'll hope to show you why. Endometriosis is a common gynecological condition affecting around 5% of women. It's defined by the presence of stroma and glands outside of the endometrial cavity, and this is hormonally responsive, leading to cyclical pain, bleeding, inflammation, and later fibrosis and the formation of adhesions. This causes pelvic pain, painful periods, pain on having sex, pain on opening bowels during period, subfertility, or it can be entirely asymptomatic. We're still not sure what causes endometriosis. In this image, we're looking at the back of the uterus with the left ovary here and the right ovary there, and this illustrates that there are different kinds of endometriosis. There's superficial endometriosis, which just affects the peritoneum, and we won't be talking about this, but also ovarian endometriomas and deep endometriosis, and that's what I'm mainly going to be talking about. Typically, there are long delays between the symptoms and the diagnosis of endometriosis, and worldwide this is about 8 years. Many women consult their GP many times before they're referred and diagnosed, but there is significant overlap between endometriosis and other conditions such as irritable bowel syndrome, which makes diagnosing endometriosis more difficult. You can see what a huge impact endometriosis has on people. This is from the oral histories of 21 patients done by Janine George on Twitter, and you can see what impact endometriosis has on people's lives. Many people with endometriosis have a structural pelvic ultrasound, which is said to be normal, and patients are told there is nothing wrong. And this is one of the things that leads to long delays in diagnosis. Many patients have such bad pelvic pain that they use hot water bottles, and this can cause this damage to the skin called erythema ab igni. And so traditionally, the only way to diagnose endometriosis was at laparoscopy. And this is what we look for. At laparoscopy, the camera is inserted through the belly button and you look toward the patient's feet. So here we're looking toward the patient's feet at the back of the uterus. And a normal pelvis looks like this. This is the uterus, there's the right ovary and the left ovary tucked under there. This is bowel at the back, and you can see the fallopian tubes. This is the pouch of Douglas, and you can see everything is nice and free and looks healthy. But a patient with deep endometriosis, this has caused extensive adhesions and for the ovaries to be low in the pelvis. And you can see that at laparoscopy, you can't actually see very much more, just that there are really bad adhesions. This is called a frozen pelvis. Now, when people have an ultrasound, this is usually just a routine pelvic ultrasound, which mainly looks at the uterus and ovaries. But you also need to look for deep endometriosis, mobility, looking for a frozen pelvis, and site-specific tenderness. In 2016, this paper was released from the IDEA group, giving us a system and language to use for ultrasound and endometriosis. Language really matters, and this is the IDEA language. So in this diagram, you can see the bladder, the uterus, the vagina, the bowel, and the pouch of Douglas. And if you draw a line where the bladder attaches to the uterus, you pass through the internal os, and at the back is an area called the torus. If you draw a line underneath the cervix, then the line between the vagina and the bowel is the rectovaginal septum, and it stops here. And the top bit of the vagina here is called the posterior vaginal fornix. Now, these two bits of terminology are very important. So below the cervix, this is called rectovaginal septum. Above it is called the posterior vaginal fornix. And then the reflection of the peritoneum in the rectouterine pouch is called pouch of Douglas. That's just there. And then the bowel from the anus up to the level of the torus is called the lower rectum. From the level of the torus up to the uterine fundus is called the upper rectum, and above that level it's called the sigmoid. Now, in the posterior compartment, that's to say the area behind the cervix, behind the retrocervical area, we call it posterior compartment, is a very common location for deep endometriosis. You can see it here in the posterior vaginal fornix, level at the torus, in the lower rectum and in the upper rectum, or it can all grow together, and at this point you have a frozen pelvis. One area where you virtually never see endometriosis is in the rectovaginal septum. So the posterior compartments consist of the vagina, the ligaments and the bowel. We also look in the anterior compartment, mainly at the bladder and at the ureter. So in the IDEA system, they suggest that it would consist of 4 steps, and you can do them in any order, and this is how I do it. So I start with a systematic routine pelvic ultrasound, looking for features of endometriosis, such as adenomyosis, ovarian endometriomas, and ovarian adhesions. And so I usually ask the patient to empty her bladder, but we don't use a routine bowel prep. And the main thing to say is that you need to be really gentle. Patient positioning is very important. I have the bottom overhanging the edge of the couch a bit, with knee supports or feet on the chair. And then I say, let your knees go floppy, and then slowly insert the probe with plenty of lubricant and perform a systematic pelvic scan, also noting mobility and tenderness. And I will also do a renal scan in women with endometriosis, because about 3% of them will have silent hydronephrosis. And this is how I orientate my transvaginal probe, with the marker uppermost, and you get this fan of sound that's displayed marker to marker. So the upper side displays to the left side of the screen, the lower edge of the fan to the right side of the screen, and so this would give me a longitudinal plane. This is what it looks like on ultrasound, again with the top marker is displayed there, and you can see this is a longitudinal view of the uterus, as though you're looking at the patient in this position. And that would then correspond to the bladder, vagina, uterus and the bowel. Uterine position. Now, this is an anteverted uterus. It is toward the bladder. This is a retroverted uterus, away from the bladder. This one is anteverted. It looks like the cervix is going to go up that way, but then tucks backwards. That's retroflexed. And then this is an axial uterus, where it's in the same line as the probe and is a little bit harder to image sometimes. Now, starting my systematic pelvic scan, looking for features of endometriosis, you can see here that this uterus is anteverted. It looks like it's going to be an anteverted uterus, but then you can see that the endometrial cavity is flexed backwards. So this is anteverted and retroflexed. And the reason that this uterus is retroflexed is because it's being pulled backwards by adhesions to the back of the uterus. The next thing we look for is adenomyosis, and this is a fantastic paper describing all the different features of adenomyosis that are briefly listed in this infographic. This is a great paper for you to read. And this is what adenomyosis might look like on ultrasound. So in this example, you can see an anteverted uterus, and it's very bulky, globular. You can see little myometrial cysts. You can see that the endomyometrial junction is very difficult to see, and you've got this fan-shaped shadowing. So this is severe adenomyosis. In this case, this patient has islands of endometrium scattered throughout her myometrium. You can see that's adenomyosis. And if you do a 3D scan, you can see an irregular endomyometrial junction, as these buds of endometrium appear to almost invade the myometrium. So the next thing to look for is an ovarian endometrioma. And that will often have adhesions. So in this case, you can see that this is a very low ovary at the level of the torus, at the level of the internal os, and you can see a cyst here. And this one is unilocular with ground glass echogenicity, using IOTA terminology. But an ovarian endometrioma can have up to 4 locules, but this is a benign looking ovarian endometrioma. And if you look in the transverse plane, it's much easier to see the adhesions, and you can see that this endometrioma is adherent here to the back of the uterus. And if you compare that to this patient's other ovary, and I'm just very gently pressing the probe in and out just here, you can see that this ovary cantilevers beautifully and it's nice and mobile. So this is one thing to look for. If you go to the transverse plane, very useful in endometriosis. This is transverse quite low on the uterus. You can see bilateral ovarian cysts. They were bilateral endometriomas, and these ovaries are kissing. They're in contact with each other, and that they are adherent to the back of the uterus. So endometriomas are usually ground glass echogenicity, but they can be anechoic. Now, ovarian endometriomas are rarely isolated, so if you see this, go looking for deep endometriosis. What you commonly see on scans for women with endometriosis is that the endometriosis hasn't been recognized, but the sonographer has seen that the ovary is low. And if it's low, you have to think, why is it low? Is it adherent to the back of the uterus? And again, in the transverse plane, you can see that this patient, the ovary is adherent to the torus. You can see here is the torus. This is where the uterosacral ligaments insert. This is the left uterosacral ligament, and this ovary is adherent to it. So having done a systematic pelvic ultrasound, next I'm going to do a sliding sign in the pouch of Douglas. Now, these papers were published in 2013, and this is now something that should be part of every basic routine pelvic scan. You do it by, this is an anteverted uterus, and I just very gently press the probe in and out a little bit. I don't use my other hand most of the time, but I might have to use my left hand on the patient's abdomen, but I don't often need to do this. Just very gently press in, and you can see that the uterus and the bowel move in opposite directions. So this is a normal sliding sign. Contrast this with this patient, where you can see that there is movement, but everything moves together. You can see the uterus and the ovarian endometrioma and the bowel, everything is glued together. So this is an abnormal sliding sign in an anteverted uterus. Now, in a retroverted uterus, you can see that this uterus bends away from the bladder. The bladder is up here. I'm now in the posterior fornix, more about that in a moment. You can see that when I'm just very gently pressing this in and out, that mobility here behind the cervix is completely normal. And if you compare that, on the left here we've got the normal, on the right here it's a different retroverted uterus. You can see there's movement, but everything moves in a big block, and that's because all of this bowel is stuck to the back of the uterus. This is an abnormal sliding sign. Having done that, I now go looking for nodules of deep endometriosis. So what is that? Deep endometriosis is where the endometriotic lesion extends for more than 5 millimeters underneath the peritoneum. This again undergoes cyclical bleeding with inflammation and fibrosis, and you end up with irregular hypoechoic solid nodules which are dark with some minor vascularity, surrounded by brightly echogenic white fibrosis, so they tend to stand out if you're looking in the right place. So in the posterior compartment you can find them in the vagina, in the ligaments and in the bowel, and in the anterior compartment in the bladder and in the ureter, or near the ureter. So let's go looking in the posterior compartment first of all at the vagina. So as I insert my probe, you can see there's cervix being pushed out of the way. I'm going into the posterior vaginal fornix in this pocket behind the cervix, and here is the posterior vaginal wall, and here is a nodule of deep endometriosis. And what that looks like, you can see it's just a thickening of the vaginal wall with little cystic spaces in it. So this is the cervix, external os, and the internal os is up there somewhere. So I've gone into the pocket behind the cervix, the posterior fornix, and this is a not uncommon place for women to have deep endometriosis. And this is what that looks like on a speculum examination. You can see this bluish tinge to this cystic lesion in the vaginal wall. Next, in the posterior compartment, I look at the ligaments, at the torus and at the uterosacral ligaments. So what do I mean by that? Again, at a laparoscopy, you're looking toward the patient's feet, so toward her feet. So this is right and this is left. It's the opposite to ultrasound. This is the back of the uterus. So that's the back of the uterus, and this is the torus. And the torus is just the area where the right uterosacral ligament and the left uterosacral ligament insert on the back of the cervix, and it's level with the internal os. So this is a very important area in endometriosis, together with these ligaments, and that's what we're going to look at next. So how do you visualize the torus? I start off in the longitudinal plane. You can see here, this is an anteverted uterus. This is all cervix. This is where the bladder inserts on the uterus. So that's that. In a straight line back is the internal cervical os, and in a straight line back, this is the torus. This is the area we're going to look at, and this is the position how we start. So I'm starting my scan in the longitudinal view. I turn on the internal os into the transverse plane, and I'm now at the torus. This is the torus. This is the area of the right and the left uterosacral ligaments. So you can barely see them. They're very, very fine lines. Again, look at the internal os, turn anti-clockwise to the transverse. This is now torus, and this is these very fine lines. These are the uterosacral ligaments. Don't worry about what they look like when they're normal. It's when they're abnormal that it matters. So in this view, these are normal uterosacral ligaments, and everything's nice and mobile against them. So again, in the longitudinal view, we had the normal torus here. In the transverse view, normal torus and normal uterosacral ligaments. And in the abnormal situation, you can see that this area of thick whiteness, this is retrocervical fibrosis. These are the uterosacral ligaments with a dark nodule of deep endometriosis within them. And this is what it looks like in the transverse plane. You can see these very thick uterosacral ligaments in marked contrast to this view here. So I like to look at the torus to find it in the longitudinal plane and look at it in the transverse plane, and then it becomes very obvious where you are. There's another way of looking at the uterosacral ligaments, and this is through the posterior fornix. And I'll show you in a minute that the uterosacral ligaments will blend in to the top of the probe, and it's just a useful concept. So here, this darkness is the posterior vaginal fornix, this white is peritoneum, there's a little bit of ovulatory fluid, and in a minute you'll see a line that does that, which is the uterosacral ligament. And then as I press my probe onto it, you'll see it becomes smoothed in to the peritoneum. So let's see what the video shows. There is the uterosacral ligament. I'm pressing now. So now this is the uterosacral ligament with peritoneum. And it's a very useful way of looking at the uterosacral ligament. So we've had the vagina, peritoneum, and uterosacral ligament, but these lines all become blended into one. So that when you now look at the through the posterior vaginal fornix, you can see a bit of vagina and the uterosacral ligaments. And if they're thick and white, you need to look for dark nodules, and that's how you'll know that they're not normal. So this is an example of that. I'm in the posterior fornix, so I've squished the uterus out of the way up there. And you can see this is the vagina, this dark layer, and it's completely normal. And then here you can see a dark nodule surrounded by white fibrosis. This is in the longitudinal plane. And the way to get to see this really well, because you're looking very close to your probe, is to use high frequency, including harmonics, go into the highest frequency within your harmonic range, and then move your focus up so that you are focusing all the beam's energy to here, and it will just pop out. So we've looked at the vagina, we've looked at the ligaments. The last thing in the posterior compartment is the bowel. So before we can look at the bowel, I just want to show you what a normal posterior vaginal fornix looks like. So here we've got the cervix with the external os, the internal os going into the endometrial cavity. This is the anterior lip of the cervix. This is the posterior lip. And this line here is the vagina, posterior wall, and you can see how that then inserts onto the back of the cervix. And the pocket there is the posterior vaginal fornix. And you can see it here, it's because it's got a little bit of air in it. So I'm just going from left to right in the longitudinal plane, showing you this nice posterior vaginal fornix. So once you start looking, it's incredible what you can see. Posterior fornix. So now I want to have a look through the posterior fornix to look at the bowel. This is just to orientate you again. There's the torus just there. So mostly when you scan an anteverted uterus, your probe is just in the anterior fornix, okay? But what we want to do is put it into the posterior fornix. So I'll show you how I do that. Once you're in the anterior fornix, you withdraw your probe a tiny bit, you angle it backwards more toward the sacrum, and then you very gently insert it past the cervix into that little pocket, the posterior vaginal fornix. And this is how you're going to see the pelvis really well behind the uterus. It's a great way for looking at bowel. So I can just play that. It's coming out again. There's a little bit of fluid in the pouch of Douglas there, normal ovulatory fluid. So there's the cervical canal. So I'm in the anterior fornix, and I'm going to put the probe in the posterior fornix. Now, we're now in the posterior fornix, and you can see there's a bit of vagina stretched over the top there, and then this is peritoneum, and here we've got a little bit of fluid. And people say when they go in the posterior fornix, oh, I don't know where I am now, but you do know where you are, because you've just gone past the cervix and the uterus, and you've pushed them up that way. So you know exactly where you are. And now you can see this bowel here, which is lower rectum, it's below the level of the torus, consists of many layers. So it starts with a brightly echogenic layer, which is serosa. You've then got this double layer. It's dark, white, dark, and this is the outer longitudinal fibers, a little bit of connective tissue, and then another inner circular muscle fiber layer. This is the muscularis. This is where you find deep endometriosis in the bowel, so a very important layer. Overlying that, you've got this echogenic submucosa and mucosa on one side and on the other side, and then you've got the muscularis on the posterior wall and serosa on the posterior wall. So these are the different bowel layers. And so you've got the anterior wall and the posterior wall, and this is where the lumen is. So this is very important to understand, because deep endometriosis in the pelvis, if it's in the bowel, it will be in this layer, and it looks like this. You can see some normal muscularis going into it, some normal muscularis coming out of it, and this is the nodule of deep endometriosis in the bowel wall, in the anterior muscularis of the lower rectum in this case. So how can you start to look for that? The way to practice it is as you insert the probe, just very slowly, having done all the other steps that we did, find the muscularis layer. It's easiest found just below the level of the cervix. You can see it just there, this dark white dark layer. And as you advance your probe, you just track it, you follow it. And it doesn't run in exactly a straight line, so you might have to move your hand a bit and rotate a bit, but you just follow it. And if you practice that, you'll get good at it. So it went up there, and then there, and then there. You can see how you can track this muscularis layer. Now this is a completely normal muscularis, and you can follow it quite often all the way to the uterine fundus, to about 20 centimeters from the anal verge. And if you practice that, you'll get really good at it. And when it's not normal, you will see very clearly that here you can see this area that is very dark with normal overlying white submucosa and mucosa and muscularis coming in and out of it. So the thick muscularis, the submucosa, that's the normal muscularis on the other side. That's the posterior bowel wall and the anterior bowel wall. And you can see how different they are in this case. When you put colour on, you can see that it's not very vascular, this lesion. That's normal for endometriosis. If it was strongly vascular, or if you saw that on the posterior wall, you'd need to think about different pathology other than endometriosis. And in this example, this is a bowel nodule, so thick muscularis layer in the lower rectum again in this case. So you can see the dark normal vagina, you can see that just there. And then you can see here the muscularis layer coming into and normal out of this dark tissue here, which is a bowel nodule of deep endometriosis. You can also see the posterior layer, which is completely normal. And in this case here, you can see I'm in the anterior fornix, and I can see something here that looks dark and not very clear. So what I'm going to do, I'm going to have a look at that by putting my probe in the posterior fornix, and that will give me this video. So if we just start that one, I want to get a better view. So you can see there's something not normal, it's very dark. I'm going to put my probe into the posterior fornix now. There's tracking muscularis, looks normal, 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 and then normal, normal, and then it isn't normal. It goes very thick and dark, hypoechoic, And this is the nodule of deep endometriosis, much better seen through the posterior fornix. So you need to break it up as you scan these patients, otherwise you'll forget to do something. So I always do it in the same way. In the posterior compartment, you look at bowel, you look at ligaments, and you look at the vagina. And sometimes people have involvement of all three, and that's what this patient has. So you have to be sure your probe is fully in. Be nice to the patient, be gentle. None of this has to be painful. You just have to be very gentle and remind her to let her knees go floppy. And then even in the still image, you can see this is a very thick posterior vaginal wall. This is involved with endometriosis. You can see how fibrotic the ligaments are already before you've even started the video. So if we start it, you can see I'm just in the longitudinal plane scanning from side to side, and you can see here that all layers are involved. There's fornicele involvement, posterior fornix, it's fornicele involvement. There's retrocervical fibrosis with deep endometriosis, and there's a bowel nodule as well. I'll just play that one again for you so you can see it. And here you can see there's the posterior fornix, deep endometriosis in the uterosacral ligaments, and bowel involvement. And so, particularly by gynecologists, this used to be called a rectovaginal nodule because it was in the rectum and it was in the vagina. But this is terminology we try not to use anymore. This is a large nodule of deep endometriosis affecting the fornix, the ligaments, and the lower rectum. So you can say a lot about bowel endometriosis, whether it's deep or it's superficial endometriosis. If it's involving the posterior fornix, you can say how low the bowel is, if it's lower rectum or upper rectum, or how many centimeters from the anal verge, and whether or not it's a stenosing lesion. And these things are really important for the surgeon to know if they're planning any surgery. So I think I've shown you that on ultrasound you can see so much more than at laparoscopy. Here again is what a normal pelvis looked like. This is the posterior compartment. This is the posterior compartment of this patient who has a frozen pelvis. You can see it's all glued together and you can't say that much more. But this is the same patient. This is her ultrasound. You can see she's got a frozen pelvis. All the bowel is stuck to the back of the uterus. There's deep endometriosis in the uterosacral ligaments. This ovary is adherent to the uterus. In this image, you can see an ovarian endometrioma adherent to the uterus, and that's the other ovary. And you know that everything is the other way around on ultrasound. So this one is this one. What ultrasound also showed was some bowel involvement, and you could not have guessed that at laparoscopy. Now, don't forget the anterior compartment. I always do this at the end because if people have emptied their bladder at the beginning of the scan, by the time you come to the end, there's usually some urine in the bladder, which allows you to look at the bladder wall. And these are some examples of deep endometriosis in the bladder wall. This is a very extensive, large nodule of deep endometriosis in the posterior bladder wall at the base and at the dome. And this second one is a smaller nodule, much smaller. You can see these little cystic spaces again where there's been some bleeding, and you would be able to measure the distance of that to where the ureter empties into the bladder. And this last one here is a uterus here with adenomyosis and a nodule here which is extending into the ligaments around the bladder, but it's not actually involving the bladder wall itself. Now, the ureters can be involved with endometriosis, and it's usually fibrosis around them rather than endometriosis in the wall itself. And you get fibrosis around the ureter and compression. And so in this first example, this is a hemorrhagic cyst, but this ovary is attached with deep endometriosis to the uterosacral ligaments. And you can see here that this has become adherent to this ureter, which is dilated above that area. And in order to see that, what you need to do is increase your depth of field. Don't just get stuck on the ovary, but actually go looking above it. And you can see a hydroureter there. And this is a different patient, but it shows why you must look at the kidneys because this patient had gross but silent hydronephrosis. And where you have ureteric involvement by endometriosis, you can get that. So important to at least diagnose it. And I check the kidneys in any woman with any endometriosis. Lastly, you look for soft markers of site-specific tenderness and pelvic mobility. So that I've done the ultrasound of the uterus cervix, the endometrium, the ovaries, fluid in the pouch of Douglas, but then also the sliding sign and looking carefully at the posterior compartment and the anterior compartment. So we've said what it looks like on ultrasound. So how do you learn to do this? Before you start, you need to allow yourself enough time. Now, for many departments, I know even 30 minutes is a long time to be allowed to do a scan. Many of you only get 20 minutes, but I think for a good quality standard gynecology scan, you need 30 minutes. But for a detailed pelvic scan, like I've been showing you, you need 45 minutes. I start all my scans transvaginally unless I'm specifically looking for fibroids or a patient who doesn't consent or a lady who's never had intercourse yet, because the transabdominal views are not helpful at all. Then I ask them to empty the bladder, maybe drink a bit of water at that point, but I don't use bowel prep. And I make sure that the patient feels comfortable. I lock the door, cover her, and I'm friendly and give particularly the advice about floppy legs. And then again, use a bed, not a wedge. If you use a wedge, you're never going to see anything. Have the bottom at the edge overhanging a bit and the bed a bit high. Just helps a lot to see into the posterior compartment. And I have feet on stirrups or a chair if necessary, but stirrups is nicer because then you can sit between the legs in the lithotomy position and it's much easier to see what you need to see. Now, gently, gently, gently is so important. If you are gentle, you will see much more than if it's a painful examination. So explain what you're going to do, make sure the patient knows and that she's in charge. And I say, you're the boss. If you tell me stop, I'll stop straight away. And I say, I can't talk and scan at the same time. So being quiet doesn't mean anything. I'm just looking carefully. The other thing I say, and this is the most important thing, is ask the patient to put her arms by her sides, let her bottom sink into the bed, and let your knees go floppy. This allows all the muscles in the pelvis to relax. But if you say relax, it means nothing. Give them a job. Let your knees go floppy. And then very gently and very slowly, all the while you're watching the screen, insert the probe, angle toward the sacrum. And then do your systematic scan with the sliding sign. So just start with the sliding sign. It's incredibly important. It's really nice to sit in with an expert sonographer and to go to theatre once somebody's been scanned so you can see what they have found, and then also look up reports of surgery after you've done a scan so that you can feed back on yourself. Were you right, or is there something to learn? YouTube is a marvellous resource. There's videos of patient laparoscopies there, also ultrasound videos, and this allows you to learn one step at a time, and that's very important. Break things down and only get good at one thing at a time. So start with looking for the sliding sign in all your patients. The first 20 or 30 you'll not be quite sure if things are mobile, but after that you really will. Then start looking at the torus in the way I showed you, at the level of the internal os, longitudinal, and then go transverse and look for the uterosacral ligaments. When you know how to do that, look through the posterior fornix and track the muscularis. The main thing is, if somebody has symptoms or not, keep endometriosis in your mind because it can present with all these different symptoms. And don't say that you don't have endometriosis after a normal scan until you're really quite good at it. And be gentle, really gentle. Here is some good resources, some videos and a book. I highly recommend all these different resources. You'll be able to take a screenshot of this and have a look later. And this book is a particularly good book. It's very detailed, How to Perform Ultrasound in Endometriosis, edited by Guerrero, Condas and Alcazar. It's an excellent book. And of course, there's always my website as well if you want to see any more of my videos. Thank you.